You tell me when to start, Marinas.
Will do. I'm trying to admit everyone in. Almost there. All right, Allison, we're all set. Allison, we can go ahead and get started.
I'm here talking on mute. I said hello, everybody. Welcome to our Part DJH Wiki Toolkit series, where today we are excited to have Dr. David Griffith, who will be talking about retention HIV care in rural Maryland. Next slide, Marinas.
So social work what might have a better answer.
But we need everybody to mute, please. Just a brief housekeeping. If you could please mute everybody. Briefly before we get started, Dr. Griffith is an assistant professor. Marinas, I think I'm being muted. I'm trying not to be muted.
Okay, there you go.
All right. Dr. David Griffith is an assistant professor at the Johns Hopkins School of Medicine. He attended medical school at the University of Maryland and completed a residency in both internal medicine pediatrics, med-peds, at the University of Rochester. He then completed a combined fellowship in peds and adult infectious diseases at Johns Hopkins School of Medicine. He is currently the medical director of the Johns Hopkins County HIV/AIDS program, which provides HIV care in partnership with health departments across the state of Maryland. In addition, he practices at Johns Hopkins Hospital in both the pediatric and adult HIV clinics, as well as general infectious diseases pediatric inpatient consultation service. He has a clinical and research interest in prevention and treatment of HIV, particularly in young adults. Really excited to have Dr. Griffith here today, particularly since he's on clinical service. Take it away, Dr. Griffith.
Thank you, Dr. Agu. So today we're going to talk about the challenges, but also successes of treating HIV in rural areas. It'll be mostly from my experience, which is in the western part of the state. And I'm really excited to talk about this subject that often, and I really appreciate the time to talk about it, because often it's not one that gets much attention. And so I really thanks to the organizers. So we're going to talk about.
I'm listening to yours, Rita.
We're going to talk about the challenges of healthcare in general in rural areas. We'll talk about some of the epidemiology of HIV in rural Maryland, and then a model of care that we have for the western region of Maryland, and then go through some barriers and successes in terms of how we keep patients in care. This is beautiful Cumberland, Maryland. It's where my program has a clinic and where I've been seeing patients. It is, as you can see, very scenic, but with that beautiful scenery comes additional challenges, and it's a wonderful place to visit if you all have the chance. So in the US, people living in rural areas are more likely to be older and poorer and have greater health challenges compared to non-rural areas. A lot of that has to do with access. There are fewer hospitals. Many rural hospitals in the US are closing because of changes in how hospital systems are structured and funding issues. And many areas are lacking in subspecialty care, and not a lot of folks have the means to travel to more suburban or urban areas to get their care. So all of that comes together to make healthcare a challenge in all rural areas. And that goes the same for HIV. Folks living with HIV do face those same challenges because of the need for subspecialty care. Some evidence suggests that in rural areas, there's worse retention in care, adherence to antiretroviral therapy, and worse HIV viral suppression compared to non-rural areas. And we know that retention in care is associated with viral suppression and improved health outcomes. So very important measure for us to think about when we think about the HIV cascade is how are we keeping folks in care? Now, I mentioned there's some evidence to say that those outcomes are worse. However, data from the Ryan White HIV/AIDS program shows that retention in care and viral suppression rates did not differ on the basis of services from rural and non-rural providers. So for patients who are engaged in a Ryan White service program, there is no difference in outcome. So across the board, yes, it's more challenging for folks living with HIV in rural areas to stay in care, stay on their medicines, and have viral suppression. But if there's access to a program that can provide the comprehensive care that Ryan White allows, those outcomes differences go away. This is data from the state of Maryland. It's looking at county and for people living with HIV in 2021, what percent were retained in care and what percent had a suppressed viral load. So you can see across the board for the state of Maryland, 78% are retained in care and 65% have a suppressed viral load when we look at all the counties in the state. I pull out here the counties that are designated as rural jurisdictions. And you can see a slight improvement in retention and care from 78 to 80% when we only look at the rural states, and an improvement in viral load suppression as well. So from 65 to 69%. So though slightly better compared to the state at large, these rural areas still continue to have challenges. And you can see by the graph, different counties have different challenges. You notice Cecil County has the lowest retention in care and viral load suppression. I know from talking to the health department there that there is limited HIV care in that area. In fact, only one HIV provider that I'm aware of and is nearing retirement and not taking new patients. And so that is one area where there's not access to an urban center nearby, and maybe one reason why retention is not as good there. So we'll talk about some of the strategies we have to bring care to those areas that may be struggling to keep patients. This is looking at the western region of Maryland. So that's where my team goes and where I practice. So this is in 2021 for those 18 and above, the care continuum. So starting with the red graph, among current residents in Western Maryland, of those who are living with HIV, 93% have been diagnosed, 74% retained in care, and 67% with a suppressed viral load, which overall, definitely room for improvement, especially in terms of the jump from diagnosis to retention in care. We can definitely do better there. The yellow graph is maybe outcomes that are less, not as good. So we think about 100% of those new HIV diagnoses, only 76 have been linked to care and 24% have a suppressed viral load after 6 months. So challenging getting all the newly diagnosed folks into care, and then once in care, keeping them in care and on medication. So while there are some good things that we'll talk about, there are barriers that we'll focus as well. So in the response to HIV epidemic in the early 1990s from Johns Hopkins was to extend our services outside of Baltimore. In the early 1990s, it became unrealistic to transport folks living with HIV and struggling with the disease to Baltimore for care. So in 1994, the Johns Hopkins County HIV program was born. And that started with those green counties on the map there: Hartford, Baltimore County, Carroll County, Howard County, and Anne Arundel County. So a team from Johns Hopkins would, in partnership with the local health departments, would go and provide HIV care. Actually, in the 90s, Johns Hopkins also covered the Eastern Shore, which now is covered by Chase Brexton. In 1997, the Western region was added to that. So that's Frederick, Washington, Allegheny, and Garrett counties. We have 3 clinic sites in Western Maryland: Frederick County Health Department, Washington County Health Department, and the Allegheny County Health Department. Folks from Garrett County come to Allegheny County to get their care. So we do have patients that we care for in Garrett, but we don't physically go to health department there. They're brought to or come on their own to Allegheny for their care. Carroll County, we no longer have a clinic there. They are, we see those patients in our Howard County site. In Howard County, we're not partnered with the health department. We have our own clinic site there. And that way we can see patients from different regions in the Howard County site. I mentioned Cecil County. Given the lack of providers there, we have come to an agreement with Cecil and Hartford County, where our group will be able to see the Cecil County patients in Hartford if they're newly diagnosed. So hopefully helping to add more provider options to the Cecil County Health Department when they have patients who need to be seen. So really some evolving landscape, but really, at least from the 90s, we've been very present in these areas providing care for our patients. How do we do that? We're a multidisciplinary team of providers. Physician, physician assistant, nurse practitioner. We have 2 nurse practitioners, 1 physician assistant, and then I'm the physician medical director. We have 2 nurses. We have a program coordinator. We also work closely with our Bartlett Psychiatric Services colleagues. We have a therapist and a psych nurse practitioner who are available in our Western region via telemedicine, and they actually are available in person for our counties surrounding Baltimore County. We work collaboratively with the local health departments and the case managers there. So each patient has an assigned case manager at the local health department. The local health departments do the intakes. They will schedule the patient, and then once or twice a month, our team goes to the health department, uses our Johns Hopkins laptops, sees the patient as the Johns Hopkins patient in the health department clinic. We can order labs electronically, medications electronically, and the health department will help sign the patients up for MADAP, make sure they have all the paperwork needs to get all their Ryan White services. It works really well. We also have a share care model where because we're only there a few times a month, we can provide the HIV expertise, but we encourage our patients to have local primary care doctors for the times in between when they're sick, they need a place to be seen. And we kind of send our notes and feedback to the primary care doctors what we're doing with the HIV and help educate in that way. Also, as our patients age, they have a lot of comorbidities, and us coming once a month is not the best model for managing more complex issues like diabetes and hypertension. I will say many of our patients would want us to do that. We all know how challenging it is to get into your primary care doctor after your primary care doctor retires or moves. Finding a new primary care doctor is really challenging. So oftentimes we do fill that role as the primary care provider because we've been the continuity for them over time. And we do our best to kind of more bridge to a new primary care provider when our patients need us to. We have high patient satisfaction and excellent clinical outcomes. From 2021 to now, we have 95% retention in care and 93% viral suppression. Now, those are patients that we're able to see in clinic. We do have some ongoing quality improvement projects because there are patients who are lost to care, especially in COVID when health departments had to pivot to COVID. We had patients who kind of were lost in the mix, and we've been going back and contacting some of those patients to make sure that they've been reconnected to care either in other places or if they need to get back into care with us. So that's an ongoing process for us because we have lost some folks over the years in terms of retention. We do really well. We have high retention rates. We provide this continuity. We have patients who've been in our program for 20 plus years. And that's really important, especially in these rural areas, to provide that continuity, that there's someone who patients can talk to about this medical problem that they may not want to talk to others in their community about, and that continuity is essential. We also work really well with the comprehensive case management program at the local health departments. And in some ways, this can be benefited by a more rural area because there's fewer patients. So the case managers can have a more focused approach to those patients. Sometimes the needs are labor intensive as well. So that focused approach and lower patient to case manager ratio is essential. And then we have really strong ties with local community. We can, through the local case managers, link to other services such as mental health and substance use programs, or housing, food assistance. Because we're in the health department, we have access to all the health department resources. And so though we are coming from Baltimore to do the HIV program, the patient has a local care team that can help with the local resources. So overall, huge successes in our program. We're continuing to be funded by the state to do this work, but there continues to be barriers as well. So this is kind of, in my experience and in talking to the case managers and other my colleagues who do this work, what are the ongoing issues seen in the rural areas that we need to focus on? One is ongoing HIV stigma and privacy issues. Poverty is a large issue in many of our areas. The difficulties of transportation, the challenges of healthcare infrastructure in this rural area, as I mentioned, just there are not a lot of services always. Mental health and substance use disorders are ongoing challenges, just like in urban areas. And changing demographics, which I'll talk more about. Limited access to long-acting injectable medicines is a huge challenge for many patients. And then there's both the promise of telemedicine and its challenges. So I'm going to focus on each of these one by one and share some patient stories that highlight these issues. So they're small communities, and that small community risk breaks in confidentiality. So all of our clinics are based at the health department, which are large buildings, and people have neighbors, relatives, friends who may work in the building. We have patients, a fair number, who ask to come in through the back door of the clinic. Or patients who don't want to be in the waiting room, so they wait in their car until it's time for their visit, and then they get a phone call, and then come in quickly directly into the exam room. I saw a patient last week in Cumberland who had his hat on, his mask on, kind of really concerned about being recognized in the clinic. So that can be a barrier to retention and care when patients don't feel necessarily like they will have their privacy. We do everything we can to mitigate that through the different entrances, different times of day for appointments, but it is an ongoing challenge. I saw a patient last week in Cumberland who doesn't use their local pharmacy because they don't want the pharmacist to know their HIV diagnosis, so they use a mail order pharmacy. But when there are issues with that mail order pharmacy for some of the other medicines, so there's a cholesterol medicine that there was a problem with the mail order, and the copay was a lot at the local pharmacy, but rather than use the MAD app to cover the copay, the patient paid that money for the copay, even though it was more than they could afford, because rather than show that MAD app card to the local pharmacy, they'd rather take the financial hit. So these are things that patients are constantly having to negotiate in these areas where they may not have the anonymity that more urban patients have. And I should also mention, please speak up if you have any questions along the way or similar stories that you want to share in the areas where you work, whether they're urban, suburban, or rural.
Hi, it's
Yeah.
Siobhan Solano
Hi.
from the Bartlett Clinic. And I had opened the first pharmacy for our clinic, built it and opened it way back in 1997. And we had the same problem with stigma. Number one, for patients coming to the Moore Clinic. If you were coming to the Moore Clinic, people would know right away what your diagnosis was. Equally with patients with our pharmacy as well, had some issues with but the thing that was nice about us having our own pharmacy for the clinic was that it didn't it did not put their business out into the areas where they lived, if they lived in the county or further away. So many years ago, we ran into the same issues in our clinic in East Baltimore. So I just wanted to
And-
comment on that.
And I should say that the Bartlett Clinic is the resource our patients use when they want to use the mail order. So the efficiencies of the mail order services through Bartlett really does help patients even out in Western Maryland. So
Yeah, and I think that, I mean, and that is why Dr. Bartlett had wanted his own pharmacy, was for, number one, to have people who were pharmacists that were experienced in HIV, as well as that it would be a place that our patients could go to, where people that in their neighborhoods generally, although East Baltimore is a lot of our population, however, who lived elsewhere, that no one would their local pharmacies would not know what was going on in their lives.
I hadn't thought about this or thought to mention the pharmacy issue, but it does raise issues too with some of the smaller local pharmacies having not stocks of the
Absolutely.
antiretrovirals. And so I think for sure my patients in Western Maryland are more often having gaps between refills because of some of those challenges, where our patients in the Bartlett Clinic can kind of show up at clinic and almost certainly get their medicines. Our patients often have more challenges. And then obviously poverty is a challenge no matter where you live. In talking with the case managers in Western Maryland, there seems to be more of an acute issue of late. A lot of it has to do with just rising costs of living, cost of food, utilities, transportation, and they're seeing patients who are having to make a choice between expenses. So when you can't pay all of your bills, which bills are you going to pay? Housing is a huge expense, even with the relative low cost of rents in a place like Cumberland or Allegheny County. Many patients are unable to make that expense. So just like in Baltimore, we see a lot of our patients facing eviction. It's the same issue in Western Maryland, and there often are not a lot of other options for our patients there. And so just the day-to-day struggle of where you're going to sleep, where you're going to get your food, and means that the choice of attending a medical visit for your HIV often falls lower on that priority list. And so I do think this has been a shift over time, and with rising costs of living, we need to continue to provide services. We have the patients in Washington, the case managers in Washington County will actually go to the grocery store and buy groceries and drive them to their patients, because there's no grocery delivery. The patients often don't have transportation. There's no bus they can take to get to the grocery store. And so huge effort takes, half a day for the case manager to make sure their patients have food for a few weeks. And they can do that because they have the resources, but without those resources, the case managers can't help their clients get food. So food pantries are wonderful, but don't always solve the problem. It's often a problem of getting those resources to the patient, and that's a labor-intensive process. And patients live, over an hour from the actual clinic site sometimes. And I already mentioned this with poverty, but transportation. So patients live far from healthcare facilities. Patients who don't have cars, there's no public transportation options. There's no Uber in Allegheny County. You can't just get a ride. You need to have one of the 2 cab companies set up a ride for you. And as you can imagine, when there's limited options, those options fall through, and getting patients into clinic can be very hard. Getting them to their subspecialty visits can be a challenge, and those missed visits definitely have an impact on health outcomes. Speaking to one of the case managers in Washington County, they had a new diagnosis of a patient in Washington County, in one of the more rural areas of the county, who didn't have transportation, and it cost them $120 to get that patient a ride to the health department for their intake. It's just that sort of cost is just not sustainable over time for their transportation budget. So it is a huge challenge, and the health departments then have to make choices about how they're going to spend their funds and how they're going to keep those patients in care. We'll talk about the role of telemedicine in all of this, but when there's no bus and cabs are a challenge, how do we get patients where they need to go? I haven't been following the chat, so if anyone has any comments, please speak up or
It was just Allison,
yeah.
was commenting briefly on housing. We heard on planning council meeting earlier this week that due to some formula change, the rural counties no longer qualify for HOPWA funds. And so that, I think they're trying to work on a workaround of some sort, but that sounds like may have major impact on what may be happening in some of the rural counties.
And we're seeing with kind of more urban sprawl, like patients of mine living in Frederick, which is, less rural certainly, but as the suburbs extend from Washington, the rents are going up in places like Frederick. And so the affordable housing is getting actually further from many of the core centers of patients' care. So it's certainly evolving, and those sorts of HOPWA and other resources are really essential in these areas. So I hope they do find a fix to that. So I talked about the healthcare infrastructure in some of these areas. So finding a primary care doctor is hard everywhere. I get that. But when there's fewer offices, and one of the challenges we have in Cumberland is just fewer accepting new patients. And getting patients into that care. As our program, we're there once a month, twice a month. We can certainly do a lot of this, but we run into our limitations as well with our role. And so really, ideally, patients can see someone, but that's not always possible. And we can fill the gap, but when patients are on multiple medications, needing multiple blood pressure checks and diabetes meds, it gets hard to do that when we're based in Baltimore. Limited providers for eye care and dental care. We just don't have places to send folks for dental care. A lot of the health departments get dental funds through their state Ryan White funding, and they're able to use those dental funds to dentists, but not all dentists accept that. Not all dentists will work with the health department on payment. And so there are times in Cumberland where there's just no dental care available to patients. Same with vision. It's very hard to get routine vision care. Along the same lines, access to preventative healthcare can be difficult. Right now, you can, last I checked, you weren't able to get a screening colonoscopy in Allegheny County because the gastroenterologists were prioritizing the more diagnostic and therapeutic colonoscopies. And so our patients are defaulting to using the Cologuard, which at least there's another option. And I did have a patient with a positive Cologuard and was able to then get scheduled for a colonoscopy. But these are routine tests that are essential, and they're just not always available in some of these communities. Another challenge for us is access to high resolution anoscopy. As we do screening for anal cancer, there was a time in Allegheny where we had nowhere to refer people locally. So there's no value in screening if you can't actually intervene upon that. So we had to pause screening, and now working with a surgical group in Garrett County are able to refer patients. But again, that's having to travel outside of Allegheny all the way to Garrett County to get care. It is closer than going to other centers, but is a burden on patients, and it can have true impacts on their health, given what we know about the high risks of anal cancer in individuals living with HIV. Substance use disorder, again, problem everywhere. So it's not unique to rural areas, but may have a different flavor or feel. In my Western Maryland clinics, I see a lot more methamphetamine use and still opiate use disorder as well, but it seems to be a lot more methamphetamine, which has its treatment challenges. There's no medicated assisted treatment that's been proven really effective for methamphetamine use. There's certainly approaches that can be tried, but it's very hard for patients that struggle with methamphetamine use to get the support and care that they need. There are a fair number of treatment facilities. In fact, many of our patients from Baltimore City end up in Western Maryland for their treatment. And then a lot of them end up then staying in that area. So I have many patients who are originally from Baltimore and came out to Western Maryland for their drug treatment and then have settled there. So those resources are available. It's often the challenge of getting patients into those resources that is hard. Again, limits of retention, competing priorities, patients who are not thinking about their long-term health and thinking about their drug use needs are harder to keep in care, although not necessarily harder to stay on medicines. We have plenty of patients who take their meds every day despite missing visits and ongoing substance use. High risk of overdose, and then with any substance use disorder, multiple medical and psychiatric complications. And so, like I said, it is something we see everywhere, but definitely higher rates of methamphetamine use and higher rates of when we've identified kind of networks of injection drug users and outbreaks of HIV, it's often in these rural communities where it's a smaller network of individuals who may be using the same needles. And so there's a higher risk of a smaller network in the rural community. And then so once HIV enters that community, it can be more rapidly spread. So definitely important that we work with the health department partners for syringe services and peer navigators. In Washington County, we have started having a peer navigator come to our clinics. We lost 3 patients to overdose in a matter of months in Washington County. So now we have one of the county peers will come to each clinic and just be present to check in with patients. Again, because it's a small community, the peer often knows many of the folks that we're asking him to speak to, which can be a positive because it does allow for those connections to be made. And if someone's not necessarily ready for treatment, at least they have a phone number or an individual they can talk to when they are ready for treatment. So we've been trying to work on different strategies to provide as much services to our patients as we can, because we don't often know the extent of their substance use until it's too late. And this has been over the past few years, we've had an increase in non-English speaking patients in Western Maryland, primarily Spanish speaking individuals. And many coming from South America and settling in Maryland. Frederick and Hagerstown have seen very large influxes. And so I would say for the past 12 months, the majority of our new patients entering clinic in Frederick are Spanish speaking. And it's a mix of individuals who are living with HIV, had a diagnosis in their country of origin, and then are coming to the US and then establishing care with us. And we've also had a lot of new diagnoses among Spanish-speaking patients. This is it's 2 different challenges. One is how do we get testing into the community so that those living with HIV are diagnosed and engaged in care. But separately, people who come to the US often on antiretroviral therapy from their home country, how do they then link to our clinics? I have a patient who came from the US from Mexico and was living here for almost a year, getting meds shipped to him, getting Biktarvy shipped to him from Mexico, because he just didn't know how to get it in the US. He was looking online, talking to people, being, not sure how to ask because he didn't want to disclose his status. And eventually through another website, got connected to the health department clinic and was able to establish care. But that was after he had run out of his medication. It wasn't able to continue to get them shipped from Mexico. And so we, beyond diagnosing patients who speak Spanish, we need to make it people who speak Spanish aware of the services that are available to them. We're very lucky in Frederick to have a bilingual navigator who is part of the kind of testing and outreach team. And he's been able to develop a strong network within our patients, and has even created a support group where once a month he has anywhere from 6 to 10 patients who speak Spanish coming to a support group. And so that has also helped diagnose new patients. So patients who have a cousin, I had a patient whose cousin came from Mexico to join him. He was worried about his cousin. He convinced his cousin to get HIV tested, and he was in fact positive. And so, or I have a patient whose partner came to join him and also had an HIV diagnosis, need to be connected to care. So the more networks we're able to make, the more outreach we're able to do, the more we're going to connect patients to care, so that patients who already have a diagnosis can get in care, and patients who have yet to be diagnosed can start their process. All this is challenging. Language is a challenge. We are lucky on our county team. We have 2 certified bilingual providers who speak Spanish, so we can do the medical visits. The Frederick County Health Department has an in-person county interpreter who comes to all the visits. It's always one of 2 individuals, and so that really helps because there's continuity not only for medical care but also with the interpreter, because much of what we discuss can be sensitive, and so it's nice to have the trust of the interpreter as well as the provider. So there are things we're doing to improve things for our Spanish-speaking patients, but there's more to be done. We need more resources, more outreach, more materials that are in Spanish for those patients. There's also concerns. A lot of our patients have concerns about coming to the health department for their care, and so we have to do our best to reassure them that this is a safe place to get their care. And then we all know, we've all probably seen patients who get on their injectable antiretroviral therapy and just their life changes. There's a new freedom, a lightness to them that wasn't there when they were taking a medication every day. And so it's really important, not only for patients who struggle with adherence to keep them suppressed, but also for mental health. I think it is a tremendous benefit to patients. However, we also know that getting access to it is a challenge, and it's multiple fold in our rural areas. We have yet to figure out a way to have consistent access to long-acting injectable antiretroviral therapy and PrEP. And so it's something I continue to rethink and work on and try to find different partners. But the logistics, I've yet to be able to crack it. And so anyone who has had success in expanding long-acting outside of kind of academic and urban centers, I'd love your advice, because patients are asking for it. They want it. They are in many ways entitled to it. And I think we're reaching a point where saying it's just too hard is no longer an option, and I'd like to find ways to get around that issue for our patients, because it can be tremendously beneficial. Our patients just can't come to Baltimore to get their medication. It's not realistic. And then lastly, often when I talk about what I do, and we go to these health departments, people think about, oh, well, can you just do telemedicine? Wouldn't that be easier? You could see patients more frequently and wouldn't have to go there. And I think in theory, that's a good idea, but it just doesn't always work. We have a lot of issues when we try to do telemedicine, internet access, cell phone access. Patients who are older don't feel like they're tech savvy. Some of our patients just don't know how to do it. Privacy issues for patients who live in multi-generational homes or with roommates. And because our patients have such a long history with us, and this may be the one place where they do discuss a lot of their health issues and mental health issues. They really benefit from coming to the clinic, sitting down and having these one-on-one visits. They meet with their nurse case manager one-on-one. They kind of meet with the staff, and it really is, I think, beneficial to be there. I tried to convert one of my clinics in Cumberland to telemedicine when I had a conflict, and I think only 2 of 8 patients felt like they were comfortable doing that. And so it is not the answer. It's a great tool for when we can use it, but it does not replace what we do. And I think it's important we all understand its benefits as well as the limitations. Patients just aren't able to do it in many ways.
I just wanted to mention what you're talking about now, converting people to telemedicine as well. This is Siobhan Solano again from Johns Hopkins. With our program Project Link, we are often the only support that our patients have. And patients really, I think, benefit from coming in and seeing us in person. And so I do agree with the idea that telemedicine isn't perfect for everyone.
Yeah, no, I think it's, and maybe we appreciate that more now that we've gone back to more in-person visits. I felt like when we had to do more telemedicine visits, it was wonderful that we could do that. But I think understanding those limitations as we kind of evolve is important, and we all benefit from those connections. I benefit as a provider from being in the room with someone and having a genuine connection. So I just to kind of summarize, and then we can have some discussion. It's retention care. We can have excellent outcomes, and we do have excellent outcomes in some of our programs, but it requires certain things. We need good case management, and our health departments do a great job. They need support for transportation, food, coordination of primary care, and subspecialty care. Patients, if I have a patient whose diabetes is out of control, how can I get them to the endocrinologist, the podiatrist? All of those things are often beyond the patient's ability to navigate in an area where there are fewer resources. So that continued support for that case management is essential. The reason we have, viral suppression in the 90% is because we have that. There are plenty of patients in these regions who aren't in our program, which is another challenge of how we kind of get them into our clinics and get folks into care. But we have to be able to expand this case management to those who don't have it currently. And the case management, it just fosters this reliable medical care. So knowing that you can come and talk to your doctor. I had many patients who, my primary care doctor told me to do this, but I wanted to come and talk to you to make sure you agree with it. And so we are often the longest medical relationships our patients have had in these areas. And so we are building that trust and understanding, and it's important that we continue to be there for them. And then meet patients where they are. We always have new challenges, and we have to be creative. Getting in a car and driving to the patient's house to deliver them food is a great example of that, because there is often not another person who's going to be able to come in and solve that problem. And so I think our case managers in the rural areas, a lot falls to them, but they rise to the challenge and address each of them with gusto and really creative energy. And so I'm in debt to the local case managers that we work with, and I hope they can continue to be funded with the resources they have been. And that some of that has been cut. Thankfully, the HIV services have been maintained, but some of the other navigation, testing, and PrEP and things have been affected by recent budget cuts. But hopefully, the case management will continue to remain unaffected by those cuts, because it's really why patients do as well as they do. So I'm going to stop there. I hope I gave people a sense of what it's like to practice in some of these less urban communities. A lot of overlap with what we do in the Bartlett Clinic in Baltimore, but a lot of nuance and differences as well. And it's really a joy for me to be able to practice in those places and understand the different challenges. So I will pause there for questions or just people's thoughts or comments. I appreciate it.
David, that was fantastic. Thank you for that. You know, I have so many thoughts, but there was a question in the chat about oh, I've just lost it. It was a question about essentially any must-haves. She talked about there being in a county clinic and there being only 70% retention around PrEP, and any must-haves to make it work or to improve outcomes. I hope I got your question right? Lydia Stockslater, you can unmute and ask your question because I want to make sure that I reflected it correctly. She's saying, would you be able to? Oh, go ahead.
Okay, no,
She's
so,
on the microphone. Okay.
I think
Yeah.
you know, the must-haves is that in-person connection, the individual who can do the outreach, make the phone call, drive the car, and get there to get things done. So you know, we work with PrEP navigators who are connecting patients directly to PrEP services. So that's a person. You know, I think giving someone a phone number and saying this is how you get PrEP is not going to be as effective. Having a person who says, let me help you schedule your appointment and make sure you have a ride to that appointment is going to be more effective. So I think it's investment in individuals. The more individuals from the local community who look and sound like our patients, the better impact they're going to have. And that is why I think we have such success with our Spanish-speaking navigator in Frederick. It's really remarkable to see what he's done, the community he's built around patients, and that's 99% because of him and his outlook and the approach to things. So I think it's about people and getting the right people in those roles.
Yeah, completely agree. And I think your point was well taken. I know much on our minds are the recent budget cuts, you know, announced this week, or last week and over the past few weeks. And the case managers, oftentimes the community health workers oftentimes are the ones who can't bill or what have you, but they are really the core of it all in terms of you can write prescriptions and we can spend our 20 minutes or 30 minutes, but it's who then helps people get to where they are because they meet them where they are. So thanks for highlighting that. I'm sorry, my camera's not on. I just realized I'm a black box and not sure why. Other questions? I see Siobhan. Siobhan, thank you for giving us that historical perspective. And wondered if you had any insight.
Oh, sorry. There was a question. The same lady had the same question about the retention and how we built on that. And I think one reason is that the case managers, we can provide transportation, so we can get each patient a ride to their visit. Every visit, every patient, we can get a ride, assuming we continue to have those funds. You know, that guy who's $120 cab ride, I don't know how long we can do that, but for the most part, we can get patients to their visits. And it's a lot of phone calls. It's a lot of effort. It's a lot of reminders. All of our patients will get their labs done before their visits. So they know their visit's coming up. They get a ride to the lab. Once the lab's done, they know at the next visit, we'll talk about the lab results. And so it's labor intensive, I think is the answer. It's a lot of what I'm going back to. It's about the individuals. Yeah.
Awesome. Siobhan, you came off of mute. Go ahead.
Oh yeah. Well, thanks, Allison, and everything. And been working in this field since 1991. Started out as an ACTG pharmacist, and then switched over to the School of Medicine 20 some years ago. And been working with patient education and adherence then for the last 23 years, and it's been so rewarding. And these challenges are definitely still a problem. We've come a long way with medications and the whole thing that you're talking about, Dr. Griffith, with even these. I'm excited when we can have once weekly oral medications that could be done directly observed, which would be great. I had done that with a few latent TB patients several years ago. Once a week, they'd come in and get their medicine and off from me, and that really helped out a lot. It's a challenge, and I have to tell you, the navigators are the major part of our adherence program as well, Project Link. So I have to commend all patient navigators and then it's just an exciting field to work in. I've loved all the patients and all the providers for the last, since 1991, working in HIV. So I'm aging myself. But thank you. And the presentation was great. It's great to see that your retention rate is that high and all. Ours is not that high. So it's good to see to hear some of the things that you're doing and all with regard to that. So thank you. Thanks, Allison. Thanks for letting me make some comments. I appreciate
No
it.
worries. I wonder if you could comment a little bit about testing and diagnosis. And I may have missed this in terms of, I think oftentimes there's a picture of who's at risk and where people may be at risk, and we focus on Baltimore or other places, but wondering if you're seeing people coming in later in diagnoses, or are they less likely to be diagnosed early, or maybe talk a little bit about how people embark on that continuum.
Yeah, I think you're right. We do see patients presenting later. Many of our new diagnoses come through like an STI screening for patients who are kind of self-identifying risk and coming for testing. I'm reminded of a patient who works as a farmer in his 40s, presented with kind of chronic headaches to the local hospital and was diagnosed with cryptococcal meningitis and had a HIV test and a CD4 count that was, in the double digits, and had no risk factor other than, a handful of sexual partners over his lifetime. But really, it speaks to, it could be anyone, and so it is hard. He's certainly just reminding us that all patients need to be connected to primary care and get routine screening, because it is, many of our patients are diagnosed without significant risk factors. And often are presenting sicker. We have a lot of patients who come and go, they come into care and then they move, and then they're very transient, and sometimes that can also impact the severity of their disease, because they have moved away and maybe aren't getting the same services they would have gotten other places.
Great. I think the other question I had is you spoke, it was peppered all through, but I'm just going to highlight what it is, the workforce issue, right? Because what I heard you say is that you guys are providing HIV care, but if you weren't there, there'd be nobody providing HIV care, and PrEP is another piece. And wondering what your thoughts are about further building up whatever workforce there is there to take on some of the HIV care or the PrEP, or just thinking about how we can extend or really just build that up, and what your thoughts are about that.
Yeah, so thankfully both Washington and Allegheny County have PrEP programs separate from what we do. So in Allegheny County, there's a wonderful nurse practitioner. She does the STI testing, she does the PrEP, she works at the local substance use treatment center, just kind of does everything. And she's learning about HIV. She recently took the Johns Hopkins nursing course to learn more about HIV care. So she's, I think it's about finding that person and encouraging them. And one of the deputy health officer in Washington County does a PrEP clinic in Washington County out of the health department. Those are all small programs, 20 to 30 individuals. But there is support from the health departments to do them. Frederick has not been interested in their own PrEP program. They tend to refer to Planned Parenthood for their PrEP services. So Frederick's a little different because I think there is another option that they can refer to. But yeah, our group has started doing more telemedicine PrEP. And so that's another advantage that we can offer is for patients who don't have the local resources or don't want to go to the local clinics, we can do telemedicine PrEP. But that's a Band-Aid. It's not building a program.
Right, building capacity.
Yeah.
All right. Just want to give everybody last call if there are any other questions. I know Dr. Griffith is on service and really appreciate his time. If you have any other questions, please unmute and jump in. All right. Not seeing or hearing any. David, thank you so much. That really was fantastic.
Thanks for the opportunity.
Oh, no, absolutely. Thank you for what you're doing. I know there's a lot of driving and overnight in motels just to provide the services. Almost need a show on you. Next toolkit is optimizing care for seniors living with HIV on May 16th. Really excited to have that. And again, thanks again, everybody, for your attention. This will be available on our YouTube channel. Please feel free. And we actually want you to fill in the survey to give us feedback. If you too want to talk about something, let us know. The goal is not to just have us talk, but definitely to share. So to engage and amplify and share what we are all doing, because we all have expertise. Thanks again, Dr. Griffith. And yes, you'll receive the slides if you were on this toolkit or signed up for this toolkit. Until next time, where we'll talk about seniors. Have a good day, everybody. Take care. Thanks again, David. That was really fantastic. Really fantastic.